Hello again, everyone, and I want to thank you all so much for submitting questions to address in this virtual Q&A. As we said in the email that went out, when I conduct my patient programs, one of the things I enjoy most is the question and answer session. So this gives a little flavor to it. I hope you find it helpful and useful. For those that are just listening or watching this video for the first time, my name is Dr. Jill Farmer. I am the director of the Movement Disorder Program at Global Neurosciences Institute and Robert Wood Johnson Hamilton Hospital. And I have been recording videos and presentations during the month of April for Parkinson's Awareness Month. And I decided I'd like to keep it going a little bit longer because I got very good feedback from patients that they found it useful and helpful, and so we decided to try and do a virtual Q&A. And we'll continue to do these because the response was good and the questions, as always, were excellent. Let's jump right in. Is marijuana an option for treatment? Is the use of hemp oil for massage of any benefit? So the answer is it depends. Marijuana can be helpful in Parkinson's management, but it's more helpful for the non-motor symptoms like sleep, pain, and anxiety. How well it helps motor symptoms is a bit inconsistent. Some patients swear that it helps their tremor, others say that it gives no benefit, others say that it's worse. Pharmacologically speaking, there really is nothing to suggest that it would be of benefit to the motor symptoms of Parkinson's disease and can in fact make it worse with a phenomenon called rebound, meaning that it might help for a little bit and then once the medicine wears out of your system, the tremor might be even more pronounced. And as I tell all of my patients, I am not against using medical marijuana. I am a licensed prescriber because I think it can be helpful, but in combination with proven medications, not a substitute for the more practical medications for Parkinson's disease. And as for hemp oil, again, that really has no data behind it to say that it is better than other types of oil when used for medical massage or just regular massage. So I don't think there's any problem in using it. I wouldn't necessarily pay extra for it or seek it out if you are having good results with other types of oils that you use. But it's not harmful to try. Are hearing abnormalities, things like rumbling or out of proportion, or things out of proportionately loud, part of Parkinson's disease? That's one question from a patient. And then we had two questions that were similar, so I grouped them together. One about neuropathy and the other about neuropathy. I have prolonged neuropathy from my feet to my knees, and because of this, I've been unable to exercise and are losing ground and strength. And increased instances of neuropathy running up the entire leg. Is there something that can be done to address it? And again, a question about neuropathy. I have Parkinson's and peripheral neuropathy and have a very hard time walking and lots of freezing along with bad balance. Is there a way to address these symptoms? So the first one, hearing abnormalities are not commonly associated with Parkinson's disease, but neuropathy can be associated with Parkinson's disease, although it is not common. There is a relationship between B vitamins and their metabolism and high doses of levodopa, but this is relatively uncommon, though if patients are on chronic carbidopa-levodopa use for a long time, and what constitutes a high dose is really variable for different people, but generally speaking, anything over 800 milligrams a day may be considered on the higher end of the dosing spectrum. It can impact a neuropathy or the tingling sensations in the feet, the burning, the discomfort, the sense of fullness and stiffness. More commonly, though, the neuropathy is caused by other conditions like just age-related or idiopathic. We don't know the reason why. Diabetes, thyroid disease, caustic medications such as different types of cancer medications and chemotherapies. Those are more commonly found as the underlying reason for neuropathy. So what do you do to manage it? For the pain part of it, for the burning sensations and things like that, it's all treated fairly similarly. You treat the neuropathy as you would any neuropathy. If there's an underlying cause, treat the underlying cause. Otherwise, you're treating the irritation of the nerves, which is causing the abnormal and painful sensation. And that can be done through all different types of medications. Topical medications like compound creams, or over-the-counter medications like Tiger Balms or capsaicin. Oral medications that work on nerve endings like gabapentin or Neurontin or Lyrica or Cymbalta or Elavil or amitriptyline. And then for the balance issues that are part of it, that really is physical therapy, physical therapy, physical therapy. Ways to reprogram your body's position in space. And even though neuropathy is sometimes painful, the other thing it is it reduces the sensory input from your environment. So you can't feel your feet when you're walking, which leads to poor balance, which is why using external things like canes or walkers are helpful, because they're not only stabilizing, but they give your body a secondary input of where your body is in space. And the last thing on this list is something called balance wear. Balance wear is a vest. It's a weighted vest that you can wear that helps literally ground your body in space. So it's an external input that gives you some assistance of being able to feel your position better than if you were just using a cane or a walker alone. And this is something that is done through physical therapy, and you would get an evaluation specifically for balance wear to look to see if you could have, if it's an appropriate external device for you. Why is a Parkinson's patient more stubborn, violent, and scary? Why don't they trust people? So this is a very complicated question. This is the non-motor part of Parkinson's disease. So this is the dementia and the psychosis. This is a very scary thought and is something that most people shy away from asking about or wanting to learn more about, but it's important to know. It's also important to know that not everybody goes on to develop dementia or psychosis in Parkinson's disease. The chemical dopamine impacts all sorts of pathways in the brain. It impacts executive function and planning, and as these pathways are slowed, your thought process is slowed, which causes something called perseverative behaviors. These are the behaviors where you just do things over and over and over again, and not necessarily purposefully. But it can be really irritating, and not just irritating for the person that's doing it, but irritating for the care partner that is helping to manage the patient and their behaviors. So psychosis is different than these perseverative behaviors, and psychosis is not just hallucinations. They can also be delusions, and often they're delusions of persecution. Someone's out to get me. The medicine is going to poison me. I can't trust anybody. And these are, again, due to the disruption of dopamine in certain pathways in the brain. And those perseverative behaviors are kind of thought to be those stubborn behaviors where they just don't want to do anything, or they're stuck in a particular thought process and you can't get out. And the delusional behaviors, if they're fearful that, the medicine is poison or people are out to get them, they're not going to cooperate in, their activities of daily living, and it's going to come across as stubborn. Another type of abnormal emotional response is something called PBA, or pseudobulbar affect, and this is another term for this is called emotional incontinence. So the emotional response is out of proportion to whatever stimulus it might be. So not wild mood swings per se, but just really easily set off on edge without necessarily having an appropriate stimulus to demand that kind of response. Sometimes it can be laughing, more times it's crying or yelling or something that is really quite bothersome to experience and to witness. There are different ways to treat these symptoms. None of the treatments are spectacular in the sense that as soon as we recognize one of these symptoms, we use this medication and the symptoms improve. They're better than what we have had, but these are still very difficult behaviors to manage. So First and foremost, there's always the behavioral approach. Mirroring or distractibility is really important, especially for the dementia aspect of things. If a patient is upset or they're not cooperative or they're perseverating, if you can mirror a pleasant face or a pleasant tone of voice, then that's sometimes able to get the patient to turn and follow what it is that you're trying to get them to do. Or stepping out of the room and coming back in, again with a smile on your face or a pleasant voice, sort of breaks the cycle of whatever perseverative or stubborn behavior that they might be experiencing at the moment. There's also, making sure that things in the environment are well kept, that things are well lit, to prevent sundowning and stuff like that. So there are some behavioral strategies that can be utilized. These are difficult, but something to think about. And then medication. For Parkinson's disease dementia, the medication is Exelon. I'm sorry, that's spelled wrong on the slide, but it's either comes in a patch or a pill. For hallucinations, there's Nuplazid or Seroquel. Those are typically the most common ones that we use. And then for the pseudobulbar affect, there's a medication called Nuedexta. What's the difference between fatigue and daytime sleepiness? So this is a question that comes up a lot. As also there is a question of stiffness, that is this something that is related to Parkinson's disease, or is it something that's related to an orthopedic problem? So for fatigue is something you feel with your body. Your body can be achy, it can be slow, it can be more effortful to move things and do things, but it's not necessarily something where you feel tired. Sleepiness is something that you feel in your mind or a heavy head, that your head kind of wants to bob, your eyes feel heavy, that you just feel like you need to close your eyes for a few minutes and then things will improve. Now, this is really hard to tease out, and the lines between these are blurred. So it's very difficult to say what specifically is fatigue and what specifically is sleepiness. But Parkinson's tends to be more fatigue, usually because sleeping patterns are poor in Parkinson's disease. But even if sleeping patterns are okay and you're still getting enough sleep, you can still feel this slowness, effortful achiness to the body where it just feels tired to do something. The problems are multifactorial. So as I said, poor sleep, mood. I can't overestimate the impact of mood. And I say depression here, but it doesn't necessarily just have to be depression. It can be apathy. It can be dysthymia, which is something that is not quite as severe as depression, but just a feeling of blah and not necessarily feeling like you are coping with things well. So things that put you off your even keel or your game can lead to fatigue. Low blood pressure, this is something that can commonly lead to that feeling of tiredness or achiness in the body or a feeling of slowness, and also patterned behavior. If the behavior is in a routine, so you wake up in the morning, especially during COVID-19, you wake up in the morning, there's not much to do, you eat your breakfast, you sit down, you doze off. Or you wake up in the morning after you get dressed, you know you're going to go eat your breakfast and sit down, so you feel tired and you doze off. So these are patterned behaviors that just come about naturally, but can lead to fatigue. So if you find yourself in these patterns, what can you do to get out of them? Force yourself out of the pattern. Do exercises. Use caffeine. If you know that you get particularly fatigued at some point during the day, even if you're not terribly tired, taking a power nap can sometimes be helpful. If you have low blood pressure, drink plenty of fluids. If you have poor sleep, make sure you've had a sleep study or that your sleep is treated medically or behaviorally so that you have a better reserve when you wake up in the morning. So they're not easy to tease out. They're not necessarily specific for Parkinson's disease, but they are things that are seen commonly. And the other question that the patient asked about pain and stiffness we'll get to in another slide because there's another patient that has questions about pain. So here's a question about anxiety. I have learned that anxiety is a major factor and it seems to trigger panic attacks that, coupled with Parkinson's disease, increase the intensity of tremors and mental fog. I am taking lorazepam only if absolutely needed during the day and at bedtime tramadol. My concern is addiction, but you have assured me that the lorazepam and tramadol doses I am taking will not result in addiction or brain damage, and my question is for how long? I do like to sleep at night despite of my RLS, which is restless leg syndrome, so I have been taking the meds for a long time now. P.S. I trust you. I left that in there because it's an important part to the answer of the question. There is a saying in medicine that the poison is in the dose. So any medicine, if dosed inappropriately, can be a poison. So if used appropriately, prescribed by a trusted provider, and the meds are used for the appropriate conditions that they're trying to treat, the risk for damage and addiction is low. Lorazepam is a kind of medicine that falls under the category of benzodiazepines, and these meds have gotten a bad rap, mostly because they've been used and prescribed inappropriately. Movement disorder specialists use these medicines all the time at low appropriate doses. You do not need very high doses to get the desired response that you want. And if you're not getting the desired response that you want with these meds, you often switch to something else. So when I'm discussing the use of these medications with my patients, I say just that. We're treating a specific symptom that I know responds well, whether it's restless leg syndrome, sleep fragmentation, anxiety, whatever it might be. These medicines are helpful and useful for that. We will use the medications appropriately, not using more than we need, and we will revisit the symptoms every once in a while to see if there's something you still need to stay on. And we have the trial and error. So if the patient is concerned about being on the medication for long term, but they're still getting good benefit, I say, well, let's reduce it and see if you still need that dose. And over time, we don't just stop at cold turkey, but over time, if we reduce it and the patient's still doing fine, wonderful. We've been able to lower their meds. If we reduce it and the patient is not doing fine, then that just supports that this is the dose of the med the patient needs in order to maintain symptomatic control. We're not increasing it, we're just keeping it stable. And I think that's important so that you can be reassured that it is something that your body is handling well and that you're using it appropriately and that you're not showing signs of habituation or addiction with constant escalation of doses or a feeling of craving or a feeling of anxiety that if you are without the meds, things are going to be worse. So all of this has to be discussed with your doctor. Recent studies have indicated that the addition of high-dose thiamine, vitamin B1, shows hopeful and helpful promise for Parkinson's patients. What is your opinion? Would you advise adding this to my diet? So thiamine is relatively safe. Even at really high doses, it's very hard to have, quote unquote, an overdose of thiamine. So it's something that if you're curious about trying, there are some small studies that were not placebo-controlled, so we have no idea truly if it was a medication effect or a placebo effect, but it did show that there was some improvement in motor symptoms and cognitive symptoms in Parkinson's disease. So as any question that comes up about supplements, I tell my patients there's little data to support it, but if it is a supplement that is readily available and relatively safe, there really is little harm in trying it. From a Parkinson's point of view, thiamine will not interact with other medications that you're taking. If you have other medications on board for heart, liver, or anything else, then you should absolutely discuss it with your doctor who's prescribing those just in case, because it can have an impact on those meds. But from a Parkinson's point of view, regular old oral thiamine is not something that would be, difficult to add to your medication regimen or have a negative impact. It may not have any impact, but there's little harm. But it's just the oral form, let me stress. Do not look for specialized Parkinson's disease forms with other things added to it, or seek injections or IV infusions of it. Good old run-of-the-mill B1 that you can get in any vitamin shop or drugstore is the way to go if it's something that you wanted to try. I've been taking the new drug Norians for 4 weeks now, along with an increase in dose of carbidopa levodopa. What improvement should I be experiencing? So, for those that don't know, Norians is the newest medication we have in our arsenal to help with Parkinson's disease motor symptoms. It does not work on dopamine at all. It actually has a novel mechanism which works on the A2A receptors, or adenosine receptors in the brain. The interesting part is that it has been shown that patients with advancing Parkinson's disease have more of these receptors than they do dopamine receptors. So it's actually utilizing the chemistry that the brain has to its advantage. And these receptors are in the same pathways that help control movement the same way dopamine receptors are. So in particular, these receptors are found in the pathway that inhibits movement. So if you antagonize them or if you block them, then you inhibit the pathway that inhibits movement and thereby helps promote movement. So what should you be seeing? You should be seeing an improvement in an overall stability of your motor symptoms during the day, whether that be tremor, whether that be stiffness, whether that be slowness. So if you've noticed an increase in, a decrease in your tremor or an increase in your fluidity, then type of thing that the medicine is supposed to help with. The other thing it's supposed to help with is reducing off periods. So that time before your next dose when you feel your med wearing off or coming out of your system, that is something that a medicine like Norians can help smooth out so that you don't get such a low dip before your next dose of meds. Would you summarize the most current findings on pain and PD, including pain may be present in the diagnosis stage and how medication might address pain? So pain and PD is complex. Getting back to that question earlier about I haven't done my exercise and my arm is more stiff, is it related to Parkinson's or is it related to an orthopedic issue? Unfortunately, the answer is it might be both. The short answer of how we can differentiate the underlying cause for pain is if pain improves with Parkinson's meds, it may be related to PD stiffness and rigidity. If it does not improve with PD meds, it may not be PD related. But if it does not improve with other meds for pain, does that mean it's PD by default? So when I'm discussing this with patients in my clinic, I ask the first question. When you take your medications, does the pain improve? Is your pain a stiffness? Is it an ache? Is it a burning sensation or just a generalized discomfort? Things like burning sensations are more like neuropathies, and those tend not to be related to Parkinson's disease at all, like we talked about in the first slide. But if it is a stiffness or an ache that comes and goes, that you can't really tease out if it's related to the timing of your medications for Parkinson's disease or not, then it may or may not be related to Parkinson's, and it may be an arthritic issue, it may be an orthopedic issue. If the pain improves more with anti-inflammatories like Aleve, Motrin, things like that, or regular old pain medicines like Tylenol, then those are more likely non-PD related pains. The reality is we treat the pain symptom as its own symptom. So even if the pain did improve with Parkinson's meds, but it didn't improve enough, it doesn't mean we just leave it where it is. We look for other things that can help, whether it's behavioral through stretching, hot, cold, Epsom salt baths, whatever it might be, massage, or we look to medications. We look to compound creams or medical marijuana or more traditional pain medications, whether it be tramadol or higher dose anti-inflammatories like naproxen or Mobic or muscle relaxants, things like that. So the literature has improved in the sense that it does recognize that pain is part of Parkinson's disease, but the jury is still out is if Parkinson's disease causes pain or if it's just an enhanced symptom that would have otherwise been there occurring within the context of Parkinson's. So I'm sure that's not a very satisfying answer, but that's the best we've got so far. Does Parkinson's always progress to develop tremors and other symptoms, or can these be delayed with medication and proper exercise? So the answer is no. Parkinson's does not always progress to a tremor or ever have a tremor at all. About 30% of patients with Parkinson's will not have a tremor. And the other part of that question is we do not have anything that can delay the progression of the disease. So if we have the medications that we use right now, we use them with the effect of thinking that they help the symptoms, but that they don't change the underlying pathology of Parkinson's disease. That said, we do know that patients that are well managed with the appropriate medications earlier rather than later and do participate in exercise regimens sooner rather than later have a better overall symptomatic course. If that's just because their symptoms are managed and they are able to participate in exercise and other aspects of quality of life, that they appear to have an overall improvement in symptoms for a longer period, or is there really something going on underlying in the brain pathology and chemistry? We just don't know, but it is good practice to be treated with medications earlier rather than later, and to participate in exercise programs sooner rather than later with Parkinson's disease. Hi, Dr. Farmer. Having a DVS, is or will there be an app for a smartphone to make adjustments remotely? Thank you. So there are no remote adjustments just yet, but there are ways that you can adjust it at home. So the newer DBS programmers look exactly like a smartphone. And there is an app on them that allows you to adjust your settings at home with your device. But those settings have to be programmed by me or whoever else is managing your DBS at an office visit. So you're given a range of parameters that you can adjust at home. And when you leave the office and when you are at home and you're, experimenting or experiencing symptoms or curious to see what happens, you can go up and down on your settings, but only within the parameters that myself or another movement disorder specialist have provided. There isn't an option where if you call me up and say, I'm having an issue or concern, can you just adjust my settings over the phone? We're not allowed, not that we're not allowed, we don't have the technology to be able to do that just yet. Can you speak about Parkinson's versus dystonia? I can. And I don't have a simple summary slide for this, so we'll just use the brain as a placeholder because there's just too much to put onto one slide. But I'll try to keep it brief and concise. So Parkinson's and dystonia are both motor disorders. They both impact the same areas of the brain, the basal ganglia, and they can look similar in some regards, but then in other ways they're very different. So Parkinson's disease has that classic symptom of slowness, stiffness, tremor, and balance issues. And for every person that has Parkinson's, as we said, not everyone has a tremor. So the slowness and the stiffness component may be the most presenting symptom, and that can look a lot like a dystonia in some patients, especially if it's only impacting one part of the body. For a dystonia is an abnormal contraction of agonist and antagonist muscles, so opposing muscles that are constantly being engaged that sort of bend and twist the body into a particular position. It slows it down, it makes it stiff. So if you had a dystonia of the arm and as such wasn't able to swing your arm very well and your arm was very stiff, that could look like someone with a rigid form or variant of Parkinson's disease. But what you don't have with dystonia are other things. You don't have masked faces, you don't have the postural instability per se, you don't necessarily have the bradykinesia throughout except for that one area that's affected. So there are similarities between dystonia and Parkinson's, and what complicates it even further is that a secondary dystonia can happen in Parkinson's disease. So if you are a patient that has more of the stiff or rigid variant, that stiffness and rigidity can cause an abnormal posturing of the foot, like an inversion of the foot, or a curling of the toes, or a kink of the neck. That is not a primary dystonia because this is happening in the context of Parkinson's and the increased stiffness and rigidity of Parkinson's that's causing it. So we would call it a secondary dystonia. Now, there are ways to tease out between dystonias and Parkinson's disease if clinically they're looking similar. So say you are a person that only has one limb affected and that one limb has maybe a tremor, but is also really stiff and really rigid, and you don't have necessarily the other features that are associated with Parkinson's disease, you can have a test called a DAT scan, a DAT, which looks at how well the brain uses dopamine. If there's an abnormality in that scan, then this is more on the Parkinson spectrum. If there is no abnormality in that scan, then this is part of the dystonia spectrum. Now, if you don't have access to the DAT scan, you can do the same thing with a trial of carbidopa-levodopa or fake dopamine. This is a little bit more complicated because there is actually something called a dopamine responsive dystonia, which has absolutely nothing to do with Parkinson's disease, but rather has to do with the metabolism of dopamine in other parts of the pathway, that if you replace with lower levels of levodopa than you would expect for someone to need in Parkinson's disease, they would have an improvement in this abnormal posturing or this tightness and stiffness and discomfort. So that's why I said this is a complicated topic. But typically speaking, if you're having difficulty differentiating between a Parkinson's presentation and a dystonia presentation because both the presentations involve one limb in particular that's very stiff or very rigid, the way that we do it is through either obtaining a DAT scan or looking for other things on physical exam or looking at your response to carbidopa-levodopa medications. The treatment for dystonia in Parkinson's or primary dystonia that's not related to Parkinson's, the treatment of choice is botulinum toxin injections. So as well as if it is part of Parkinson's, utilizing effective Parkinson's medication strategies as well. Are leg cramps and leg spasms common to Parkinson's patients? So the other question was a good segue into this. And not every leg cramp or spasm is a dystonia, but it can be. So the answer is yes. Leg cramps and leg spasms are really common. Muscle stiffness and rigidity are really common in Parkinson's disease, and they often happen overnight because that's when the medication is lowest in your system. So is this a secondary dystonia? Possibly. Is this related to other factors? Absolutely. It can be related to dehydration. Again, drinking, water, water, water is so important. Can it be a medication side effect? It can be related if patients are taking carbidopa-levodopa to a peak dose effect where there's too much medicine in your system, so it causes a dyskinesia or a dystonia, or a wearing off effect where there's not enough medication in your system and that stiffness and rigidity comes back. So how is it treated? Muscle relaxants, adjustments to your Parkinson's medications, or in some, home remedy fields, pickle juice. Pickle juice seems to help, and you don't need a lot of it. Something on the order of like a shot glass can be helpful. So the other question is about muscle relaxants. Botulinum toxin is in of itself a muscle relaxant. It is targeted specifically and injected directly into the muscle that is tight and stiff and relaxes the muscle at that spot, as opposed to oral muscle relaxants, which can cause you to be sleepy or groggy or things like that. And those medications that we were talking about before, the benzodiazepines, those are also muscle relaxants. So clonazepam, diazepam, lorazepam, those things are sometimes given at bedtime to help with these symptoms. Can you talk about the Pasadena and Spark studies for PD? So these are two of the newest studies that are on the block for Parkinson's disease and disease modification. They are looking at medications to target alpha-synuclein, which is the abnormal protein that builds up in the dopamine neurons that kills them off. So they're looking to use the antibodies, which are the body's natural defense against pathogens. And this can be done through vaccines. This can be done through infusions of medications called IVIG or things like that. The Pasadena study is a phase 3 clinical study at the moment, and UPenn is the closest site that is currently enrolling patients. And the Spark study is in phase 2, which is not quite clinical trial mode yet. It is the safety and efficacy side before it gets to the phase 3 trial. And they are not recruiting just yet because they just finished their phase 1 study. But these are the two websites if you had questions about the studies and eligibility, and if it was something that you wanted to participate in. Michael J. Fox Trial Finder, if you just type that into Google, that comes right up, and you can find a whole host of clinical trials that are being done that may hold an interest to you for participation. And with that, we are done.